Welcome to the Rotary Club of Milwaukee. I am Club President Darren Miller, President and owner of JM Construction. As we gather in person and virtually today, we will start by saying the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And now, fellow Rotarian Francis Vogel will give our invocation.
The venerable Zen Buddhist monk Thich Nhat Hanh says that the main affliction of our modern civilization is that we don't know how to handle the suffering inside us. And we try to cover it up with all kinds of consumption. Mindfulness is the best way to be with our suffering without being overwhelmed by it. Mindfulness is the capacity to live in the present moment, to know what's happening here and now. Han observes that most people are afraid of suffering, but suffering is a kind of mud to help the lotus flower of happiness grow. There can be no lotus flower without the mud. Gardeners understand this. Similarly, Han adds that the most precious gift we can offer others is our presence. When mindfulness embraces those we love, they will bloom like flowers.
Thank you, Francis. I'm very glad to welcome both the in-person and virtual audiences today. Whether you are here in the hall, watching live on YouTube, or watching later at your convenience, we expect you to have a quality experience. Some of you have asked about the HVAC system in the building. The War Memorial Center purchased the highest level HEPA filter capable of working with our system. You can read about this and other health practices implemented by the War Memorial in the weekly emails. And now, Beth Heller, Senior Director for Education and Strategic Planning at the Urban Ecology Center, has an announcement about Hike Milwaukee.
Hello, Rotary Club of Milwaukee. This is your Hike Milwaukee team captain, Beth Heller, joining you from the beautiful Lakeshore State Park. I'm here today to let you know about the Urban Ecology Center's fundraising event called Hike Milwaukee 2020. This year it looks a little different than previous years. We are leading small groups on hikes throughout the city, especially in the Rotary Centennial Arboretum. Because the Rotary Club is presenting sponsors, you can participate for free, but you need to sign up in order to get your t-shirt, and because we are looking to have our group sizes be smaller this year than in previous years. Small groups on hikes. For Rotary Club specifically, we have some hikes. One is, these are all happening next week. Next week, Monday, Drew will be leading a wildflower hike at the Centennial Arboretum. Tuesday, I will be leading a walk through this beautiful state park where the aster and goldenrod are all in bloom. On Wednesday, Tori will be leading a birding hike through the Arboretum. And on Saturday, October 3rd, Caitlin will be leading a hike, our favorite forester, as you know. Caitlin also is offering virtual hikes for anybody who would like to join those. Again, if you want the t-shirt, you need to sign up. So again, next week is Hike Week at the Urban Ecology Center. Rotary Club is presenting sponsors. Don't just show up though, you need to sign up in order to get your t-shirt. and because we are offering hikes that are smaller. So we have a size limit for each of those. Sign up before it fills up, and I will see you next week.
Thank you, Beth. Just click on the link in this morning's email or future emails for more information and to sign up. It is time for our next book read and discussion series. We will read Things That Make White People Uncomfortable by Michael Bennett. For those of you who do not know Mr. Bennett, he is a Super Bowl champion. Just click on the three-time Pro Bowl defensive end and one of the most scathingly humorous athletes on the planet. Bennett adds his unmistakable voice to the discussions of racism, police violence, the role of protest in history, and the responsibilities of athletes as role models to speak out about injustice. Conversations will be led by fellow Rotarian Paula Pennebaker and will take place over 3 Wednesdays via Zoom from 4 p.m. until 5:30. More information and directions on signing up can be found in your emails. The Done in a Day Committee is looking for Rotarians to partner with Milwaukee Riverkeepers fall cleanup entitled Fish Too Shall Pass. Join your fellow Rotarians on Saturday, October 3rd at 9 a.m. for a morning of autumn winds and sunshine while helping pick up along our waterways. This is the perfect way to make a difference in the community while maintaining CDC guidelines. Each Rotarian will be provided with a tote bag, garbage bags, gloves, and a mask. Just click on the link in this morning's email or future emails for more information and to sign up. Those of us who tuned in to the Thursday snack program last week had a chance to learn about the Milwaukee Academy of Science from fellow Rotarian Anthony McHenry. That program is now live on our YouTube channel. This Thursday, we welcome back Caitlin Cullen, owner of The Tandem. She spoke with us in May about the Tandem's transition from restaurant to soup kitchen during COVID-19. The restaurant is now hosting tutoring and meals after school for local students. Join us to learn more about the great work Caitlin is doing in the Johnsons Park neighborhood. For those who are missing interaction with fellow Rotarians, the informal Thursday programs are a great way to see and talk with fellow Rotarians, albeit on Zoom. I've enjoyed the conversations and learning about things that our community is doing during this pandemic. 30 minutes prior to the Thursday program, we opened the Zoom meeting for those interested in connecting with Rotarians prior to the start of the meeting at noon. If you're joining us on Zoom or YouTube today, please use the chat function to send in your questions. And now I have the privilege of introducing our speaker. Dr. Donald Berwick is President Emeritus and Senior Fellow with the Institute for Healthcare Improvement. He is also a former administrator of the Centers for Medicare and Medicaid Services. A pediatrician by background, Dr. Berwick has served on the faculty of the Harvard Medical School and the Harvard School of Public Health, and on the staff of Boston Children's Hospital Medical Center, Massachusetts General Hospital, and the Brigham and Women's Hospital. He has also served as Vice Chair of the U.S. Preventative Services Task Force, the first independent member of the American Hospital Association Board of Trustees, and the chair of the National Advisory Council of the Agency of Healthcare Research and Quality. He served 2 terms on the Institute of Medicine's Governing Council and was a member of the IOM's Global Health Board and served on President Clinton's Advisory Commission on Consumer Protection and Quality in the Healthcare Industry. Recognized as a leading authority on healthcare quality improvement, Dr. Berwick has received numerous awards for his contributions. In 2005, he was appointed Honorary Knight Commander of the British Empire by Her Majesty Queen Elizabeth II in recognition of his work with the British National Health Service. Dr. Berwick is the author or co-author of over 160 scientific articles and 6 books. He is currently serving as lecturer in the Department of Healthcare Policy at Harvard Medical School. It is now my pleasure to welcome Dr. Berwick.
Well, thank you. Thank you so much for the chance to join you. I'm delighted to be with you. I have enormous respect for the work and the spirit of the Rotary Clubs all over the country and for your Rotary Club in Milwaukee. It's an honor to get to spend some time with you. Of course, my focus, as you've heard, has been on health and healthcare for my whole career, especially the improvement of the quality of healthcare. So I'll be in a rather specialized terrain today with you. Hopefully, it'll stimulate your thinking in whatever sector in the healthcare, in the economy that you're in, and also leave some time for questions. I have to apologize in advance. This is the era of Zoom to Zoom meetings. I have another speech that I have to give, and I must join it at 10 of the hour. So I'll be with you a little bit shorter than I otherwise would have hoped. The story I want to tell you is a sort of personal journey, a journey of my own thinking about the problems of health and well-being in our communities, which came, I've been doing that for most of my career, but it kind of reached a choke point in the era of COVID. And I want to just explain what this thinking was and how it evolved for me. I'm going to try to screen share, and let's hope that works. Let me just confirm that you can see my screen. Is that okay, Michelle, Karen? Great. I have the privilege of serving on the Journal Advisory Committee and the Board of Editors of the Journal of the American Medical Association. And in that role, I was asked by the editor of the Journal of the American Medical Association some months ago to write an article on the new normal. That is, what will COVID lead to in our communities in the long run? I told the editor that I couldn't do that. I have no idea what's going to happen. What I could do is frame some choices for the new normal. This is kind of the beginning of the little journey I want to take you on here. It's like, what kinds of options is this COVID era bringing us now and for the future out of this terrible tragedy? And I ended up writing about 6 what I call choices for the new normal. This is from the healthcare lens. I apologize for that, but I'll try to make it lucid to you. The first has to do with speed. You would be very surprised, I think, to know the health services literature that shows how slow it is for healthcare to adopt effective practices. There's a famous paper published perhaps now 20 years ago saying that the average length of time it takes an innovation to go from bench to bedside, from laboratory to patients, is about 17 years. We spend a long time thinking before we act in healthcare. I suppose that's good in some ways, where there's a kind of inherent conservatism, but that has changed. In the COVID era, the speed at which knowledge is flying around, I've never seen it before in my entire career. One of the iconic stories to me was a group of intensive care doctors in Seattle, which you remember was the first outbreak in the United States. Within days of the outbreak in Seattle, those intensive care doctors were on the web and internet with intensive care doctors in Wuhan, China, where the first disease broke out, to get their coaching, to ask the Wuhan intensive care doctors, what did you learn? How do we manage these patients? What do you know that we don't know? Absolutely immediate. Within hours of that, they had produced a 3-page summary of what's known about the management of COVID at that time. And I, in Boston, got that probably within minutes of it being sent out around the country. An incredible pace of learning. We saw the National Academy of Medicine, which I'm a member, suddenly increase its pace of production of guidance. Normally, the National Academy of Medicine takes about. By the way, I'm hearing some background noise. I think you might want to mute your lines if you would do that for me.
So let me pull up my iPad, and then I'll send it right.
Perhaps you're hearing the background noise that I am. The National Academy of Sciences produces very pedigreed scientific opinions on how to manage important issues. It usually takes about a year for them to produce a report, sometimes a year and a half. It took 1 month for a new committee at the National Academy of Medicine that I serve on to produce 11 reports on managing COVID in 30 days. It's extraordinary. I've never seen anything like that. We can keep it or toss it. As COVID leaves us, eventually, I hope it will. We can decide to keep this pace of learning and exchange, or we can change it. Standardization is another issue in healthcare. There's a kind of tension between evidence-based care, where we read the science, we know the literature, and so it turns out there's a best way to manage something like a migraine headache or a cancer. But doctors have trouble with that. So they don't want their hands tied, and a lot of doctors will push back and say, I want to make the decision myself. I don't want to have standards foisted on me. And that's a source of tension. It's gone away in COVID. Physicians and nurses all over the world are seeking standards. They're asking who knows the best, who's done the best, what evidence do we have? And the pace of uptake of approaches, good approaches to managing the consequences of COVID is just, it's been astounding to me. We can keep it or toss it. We can decide in the future to embrace evidence-based standards in care, or to return to a rather more, frankly, chaotic world in which kind of everybody does their own thing. And that's going to be a choice we'll make. Another is virtual care. Perhaps you've seen your doctor in the past few months. I have, but not in person. My last visit last week was a virtual care visit, totally satisfactory. And the whole idea of visits is now on the table. And in fact, we're learning a lot about care we don't need. A lot of people are not going into care. It turns out that's just fine. There are things we've done by habit in healthcare that cost money and don't do anybody any good. And that's all being revealed in the COVID era. We can keep it or toss it. We can decide that healthcare in the future will be largely or in large measure virtual or not. There's a workforce issue we'll come back to. The one you're familiar with, of course, is the personal protective equipment. My daughter's a doctor in a Boston hospital, and for the first few months of COVID, she didn't have proper masks or gowns. They just weren't there. We didn't protect the workforce. We now understand that the workforce in healthcare is a lot bigger than doctors and nurses. It's the people that drive the vehicles that get people to the hospital. It's the people serving food, the people cleaning rooms. The workforce is enormous. And we kind of have left them out, hanging out. And we're going to talk about that a little more in a minute. Preparedness itself, we weren't prepared for this pandemic. We knew it. We knew it. There have been, for the past 15 years, a number of very pedigreed reports, some coming from our National Academy of Sciences, studying the level of preparedness for pandemics and 21st century threats in the United States, and they all showed that we were way behind, way behind. I chaired one of those groups, co-chaired it in 2018 before COVID appeared, and we had the same finding that prior groups had, which is we were not ready and we were not ready. And so our country can make a choice now, not just how will we deal with this pandemic, and right now we're not doing very well at all, but for the future when things come back, other threats will come. Will we be readier? That's a choice. And the last, and the thing that's going to occupy the remainder of my marks, is the lessons of inequity. And to talk about that, let me go back to the workforce for a minute. Here's some facts about the American healthcare workforce you might not know. More than 800,000 of our healthcare workers and 1.1 million of their children live in poverty. They're working in healthcare, but they're below the federal poverty line, according to an American Journal of Public Health study last year. That study found that 18.5 million people are employed in the US health industry, but 10% of them earn so little in healthcare that they have to get healthcare through Medicaid. And another 1.4 million healthcare workers in America have no health insurance at all. The issues of equity and justice in American healthcare affect healthcare too, and we're going to see a lot more about that in a few minutes. We have choices to make, and among the choices that COVID is underlining for us is this one. Are we going to work harder to be an equitable society in which everybody's in? You know the epidemiologic data. For example, African Americans in the United States die of COVID at something between 2.5 and 4 times the rate of whites. Latinos about the same. The Native Americans even more. The effects of inequity work their way into every corner of health and well-being in our country. Now, I'm going to acquaint you quickly with the work of a hero of mine, Sir Michael Marmot. He's a British epidemiologist who's one of the most respected in the world. Michael has done for the past 15 or 20 years a very important job of pulling together scientific evidence on inequality. Why do African Americans die more than whites in the COVID epidemic? Why do we have enormous disparities, which I'll show you in a moment? Now this is the spoiler, because he concludes that inequities in power, money, and resources give rise to the inequities in the conditions of daily life, which in turn lead to inequities in health. The term we use in the healthcare scientific world that I'm in is social determinants of health. The bottom line here is that healthcare does not produce health. $3.5 trillion of investment in the American healthcare world can't produce health. It's not the causal system. It's a repair shop. Marmot and scholars like him look upstream to try to understand, well, what is the source of disparities in illness, what makes us healthy or unhealthy. Michael happened to pull this together in a 2015 book, which you might want to put into your book club. It's a wonderful book. It categorizes, it kind of analyzes all of these social determinants, and it's called The Health Gap. Very readable, and I commend it to you. And if you read The Health Gap, you'll learn that in Marmot's view, you can sort of categorize the scientific evidence on what makes us healthy or unhealthy, what creates health in Milwaukee or unhealth in Milwaukee. And there are 6 categories that he summarizes in his book, back to probably thousands of experiments, journal papers, epidemiologic studies. The first is early childhood experiences, sometimes called adverse childhood experiences, ACEs. It turns out that exposures that kids have in their early childhood, exposures to violence, exposures to threats in their local environment, exposures to stresses, strongly predict not just childhood well-being and health, but adult well-being and health, adult longevity. Kids that have more than 4 adverse childhood experiences in their early childhood have something like 2 or 3 times the rate of cancer when they're adults, 2 or 3 times the rate of coronary disease, 10 times the rate of substance abuse and mental health issues, much higher rates of suicide. What happens to us when we're very young has a lot to do with how long we live and how well we live as adults. A second area of social determinants is the education systems. Here we have multinational comparisons, and the basics are that countries that have extremely effective education systems for their youth live longer. The causal link does appear to be in that direction. Better education is associated with longer life and better health. The United States, by the way, scores very poorly on these first 2 variables. We are the least effective country in childhood experiences in the 17 countries studied in an Institute of Medicine study of OECD countries a couple of years ago. Our education attainment, as you know, is nowhere near the best in the world. The third is work and workplace experiences. This has to do both with adequate pay. So countries that have more equitable payment systems at work, where people get incomes that are compatible with the enjoyment of life, are also countries with higher longevity. And other aspects of the workplace beyond pay matter a lot. Read Michael's book for the details of that, but it has to do with meaning in work and supports at work, not just the amount you're paid. The fourth area of predictor of longevity in societies is how societies deal with older people. Societies that have strong investments in social supports and the reduction of isolation of elders have longer life in everyone, not just elders. And then fifth is a kind of potpourri category. Community resilience is what Marmot calls it, and it has to do with community infrastructures that are very, very strongly related to lifespan, longevity, and well-being in communities. They include, for example, transportation systems, the food security in communities, housing and homelessness levels, and a kind of sense of self-efficacy and control in communities. The evidence is very, very strong that communities with strong infrastructures like this live longer. Michael pulls it all together, as he did in his comment about inequity, in what he calls fairness. And this is a difficult concept, and one that I think may offend some of you in this audience. I hope not, but it's that communities, countries, that have a sense of equity, that are unembarrassed about redistribution of wealth in the form of reaching out to poor people, really establishing a strong safety net for disadvantaged people. They have a sense of solidarity, a sense of commitment to each other. Those are the countries and communities that have the longest lifespan in the United States, in the world. The US does not score well on these variables. We score at the bottom, or sometimes at the best, sort of toward the middle of the 39 OECD countries. And even on a worldwide scale, our ratings for many of these social conditions in our communities are nowhere near the best in the world, even though we're the richest economy in the world. The consequences of these social determinants are very large. One way that epidemiologists show it is what they call subway maps, or sometimes bus maps. Here's an example. This is the London tube. This is England. And you're seeing here, this circle's at Oxford Circus, which is a kind of wealthy area of England. People that live of London, people who live in Oxford Circus have a very long lifespan. They're rather wealthy. They're healthy. Compared to people who live in East London, this is Star Lane. That's the subway stop, the London Tube stop at Star Lane. You see that the life expectancy in Oxford Circus, believe it or not, is over 90 years, 96 years. That's enormous. It's amazing. Star Lane at 75 years. That's a 21-year difference in life expectancy on a tube ride that's about, I guess, 5 or 6 miles. That is 8.4 months of life lost per minute on the London subway, 2.6 years per mile. Here closer home is New York City. This is Midtown Manhattan, again, wealthy, average income, something around $180,000 a year, generally white, in race, well-off community. Here is the South Bronx, a very stressed community, average income less than a third, probably less than a quarter of Midtown Manhattan, almost all communities of color. And the life expectancy difference here in about a 3-mile subway ride is 10 years. Loss of life is 6 months per minute on the D train from Midtown Manhattan to the South Bronx, 2.3 years per mile. So it's 6 months for every minute on the subway, 3.2 years for every mile traveled. How big is that? Well, to show you how big it is, let me show you something about healthcare. This is a British Medical Journal study about statins. I don't know how many of you in this Zoom are on statins, but I think close to half of Americans in their later years are on statins to control blood pressure, to control cholesterol and reduce their heart attack risk. This is a study in the British Medical Journal asking the question, how good are statins? How much do they help? And the answer is, it's controversial. Some statin studies show, in fact, not helping, that the ability to avoid heart attacks is actually worse on statins. I don't believe that. They probably help a little, but the most favorable finding in primary prevention trials of statin, where you just give people statins, is that 1 year statin treatment adds 1 day of life in a community trial. If you take statins for 20 years, you add 20 days to your lifespan. That's judged a medical miracle. I think most doctors would say statins are a real breakthrough in prevention of heart disease and deaths. That's equivalent to riding the D train between Midtown Manhattan and the South Bronx for 7 seconds. That's how fast you lose 20 years of life. 20 days of life. Riding the Glasgow bus, your expectation of lifespan falls 20 days and 43 feet. Now, this is a little bit deceptive because these subway maps, it's not like a cliff. It's not like every 7 seconds. It's not like a ramp. I mean, it's not like every 7 seconds you're losing 20 days of life. It's more like a cliff, because when you hit the South Bronx, that's where, as you get into the areas of deprivation, where the lifespan changes are so dramatic. This has played out in the United States health status, which, again, I remind you, is nowhere near the best in the world. We rank among OECD nations near the bottom. We're about 40th in the world, I think, lately in life expectancy, about the same in infant mortality. There was a recent rating of the overall health and well-being of populations, and among 165 nations studied, we ranked 93rd. This is what it looks like in terms of equity. Here's a funny chart. It's a little hard to understand, but basically it's about men. And it tells you the life expectancy of men at age 50. Men who were born in 1920, so their life expectancy in 1970. This is men born in 1930, so it's their life expectancy in 50 years later, in 1980, and so on, up to 1950. Look at what happens here. Almost no gain in life expectancy over this 30-year period for people in the poorest 10% of the population. For the richest 10%, really major increases in life expectancy in that same period of time. Wealth and life expectancy are strongly correlated in the United States. Here, what is it for women? For women in the poorest 10% of the population, and in the next 10%, 20% total, actually has been a decay in life expectancy of women even in the middle of the distribution, 30th percentile, compared to the wealthier population. Inequity produces enormous differences. Inequities in wealth and status are associated with enormous differences in life expectancy. Now, this is playing out in the United States in ways that are increasingly well documented. This brilliant award-winning paper by Steve Wolf and Heidi Schumacher in the Journal of the American Medical Association in November of last year studied life expectancy in the United States during this whole period, 1959 to 2017. And the result is between 59 and 2016, life expectancy increased by 10 years from 69 to 79 years of age. It peaked, however, in 2014. And we have subsequently seen a decrease in life expectancy in the United States for 3 consecutive years. Now that reversed last year. There's a little tiny improvement in life expectancy, a reduction in mortality just in this last year. But for 3 years running, for the first time in my lifetime, first time in recorded in measurements, the American life expectancy decreased. Angus Deaton, this Nobel Prize winning demographer at Princeton, and his partner Ann Case have written about what they call deaths of despair, trying to understand the components of mortality that explain this loss. And they find that alcohol-related deaths, suicide, and drug abuse, which they call deaths of despair, explain not an insubstantial portion of that decrease in life expectancy. Death rates soaring for drug overdoses, alcoholic liver disease, suicide, hypertension, and obesity, all remediable, all communities can do something about, but nonetheless increasing at enormous rates in mid-year populations, middle-aged populations in the United States over time. To this burden, this ongoing chronic issue of the relationships between equity and social conditions and lifespan and well-being, now, of course, we have been reminded of the role of racism. The George Floyd murder has, as you know, more than most people do, catalyzed a new kind of surge of concern and awareness about structural racism in the United States, going back to 400 years ago when slavery began. Of course, this is not the only such afflicted population in the United States. Latinos do not fare as well as non-Latinos, and especially Native Americans have a very high burden related again to their color and their race. The journey that I described to you mentally for me was through this terrain of science of social determinants. And it has led me to a very uncomfortable place, but it is what your leaders asked me to talk about in this meeting. And so let me take you all the way, and knowing that some of you will not just disagree with me, but perhaps even feel more strongly than that. I have been in healthcare and healthcare research for 40 years, and nothing I've told you now, nothing is new, nothing. I could have given this lecture 30 years ago with somewhat different data, but pretty much the same conclusion, that the conditions of our lives determine our health and well-being, and those are associated with very large portions of inequity and deprivation in our society. I could have told you that 30 years ago. We have known this. And yet, as you can see from those graphs of life expectancy, we have really not done much about it in this country. A friend of mine says we've admired the problem and not solved it. And I keep wondering why. I'm a healer, I'm a doctor. I trained, and my whole self-image is about life and well-being. How can my country not have improved this? And don't for a minute believe it's not improvable. There are nations all over the world that have made major, major strides on life expectancy and well-being exactly by focusing energies on social determinants. But our country hasn't, the richest country on earth, a country spending $3.5 trillion on a repair shop, isn't working on causes, not effectively. And that's led me to a pretty stiff-necked, or maybe high-minded, maybe arrogant view that we've got to check our moral compass. That I think the energy to get the changes in place that we need to address marmot social determinants is going to have to come from someplace different from where we've looked so far. And I don't know any other place to go than to ask deep questions about the kind of country we want to be, our level of caring, our level of solidarity, our level of taking responsibility for each other, not just for ourselves, islanded. If we got serious about that kind of solidarity, there's a bunch of stuff we would do that does have to do with health. For example, we would insist that our country ratify human rights treaties. We have stood aside from the human rights movement of the world. We've signed but not implemented one of the major UN conventions on human rights, but not 5 or 6. This country has not ratified the Convention on Rights of Children, not the Convention on Rights of Women, the rights of immigrants. We've not ratified conventions on the rights of workers. We stand aside from bold declarations of commitment to the kind of equity and caring for each other that, frankly, every other Western democracy has done. The second focuses on one of those, which we are the only Western democracy that has not made healthcare a human right. We are alone. There isn't one other. Some do it tacitly, some do it explicitly, but we in this country, we live with a healthcare system that leaves 30 million people out of coverage. No other country on earth, no other developed country, no other democracy on earth does anything like that. Everybody has healthcare as a human right. We don't. The Affordable Care Act made progress, covering 22 million people. In the current administration, that's been eroded. The peak of coverage in our country was reached in 2016, and every year since then, we've gone down. The third call, to me, has to do with climate change. It is one of the most massive, looming health problems on our planet. Climate change is going to result in the loss of water supply to the Asian subcontinent, indeed to parts of the United States. There'll be climate refugee problems that will dwarf our current refugee problems. And we see other effects in zoonoses, the fires in our West, and we are again alone among the large democracies of the world in having exited the Paris Climate Accord. That's not a political problem, that's a healthcare problem from my point of view. The fourth has to do with the criminal justice system. There are 2.2 million people in prison in the United States. We have people in prison at a higher rate, much, much higher rate per capita than any other developed nation on earth. There's none other, even Russia, we're higher. And our criminal justice system is the form of structural racism that offends me in some ways the most. Blacks, African Americans in our country are put in prison at about 7 or 8 times the rate of whites. Latinos at about 5 times the rate of whites. 70% of the people in our prisons and jails have substance abuse or mental health. We have no form of oversight of health systems in jails. We don't use the alternatives to incarceration that many other countries now have explored to great advantage. And we have no national agenda for adequate support of people returning from the criminal justice system back to citizenship in our society. It's a travesty, and it's a healthcare problem. The fifth is immigration reform, a very hot political topic, I know. But I must say I am, as a pediatrician, a father and grandfather, deeply offended by the way we treat families and children at our southern border. And our Congress has not taken up effective immigration reform, period. That is, it's the kind of structural defect that leads to enormous human suffering. We have 40 million people in the United States, 40 million people who have food insecurity. We have 600,000 chronically homeless people in our nation. We are a nation wealthy enough to end hunger and end homelessness. It isn't even that expensive. And yet we are unable to recruit the energies to put that at the top of our agenda. And then last, of course, is the threat to democratic institutions. In my field, healthcare, I am deeply concerned about the erosion of scientific gravitas, scientific dignity and honor in our key scientific institutions like the Centers for Disease Control and many others. And if I were in environment, I'd feel the same about EPA. And if I were in education, I'd feel the same about the Federal Education Department. We are denuding ourselves of the kind of knowledge base on the basis of which smart public policy is made. And then, of course, is the threat to voting itself. We are in real crisis mode now, wondering whether we will count people's votes adequately. And the Electoral College itself is, of course, profoundly non-democratic. in a smaller rural state in this country, a single person's vote for president counts 70 times more than the vote of a single person in an urban environment. It's a defect in, if we honor individual equity, we've set it up with defects. That's very broad. I want to just close with a quick statement about healthcare reform. You're going to be hearing and seeing a lot in this election cycle and in the future about our next wave of working on healthcare reform. 30 million people not insured, major problems in quality, an unmastered problem in the opioid epidemic, killing 60,000 people a year still. We've got a long way to go. And so when I deal with healthcare reform, I always ask these 4 questions about any proposal, either side of the aisle. Will it move us toward healthcare as a human right? Will this be a proposal that will move us toward covering everybody? Will it improve the quality of care and address our attention to the actual burdens of disease? Will it improve the social determinants of health, early childhood experiences, education, workplace experiences, the way we treat our elders, infrastructures and communities, the real causes of illness? And will it reduce our per capita costs? Because right now, healthcare is sort of confiscating resources on the public and private side from other very important uses. And there is good research to say that a lot of healthcare wastes money. We have probably in $3 trillion of healthcare expend, at least $1 trillion is just pure waste. It doesn't help anybody at all. And all of this, of course, now has to be seen through the lens of COVID-19 and the future pandemics and the lessons of the George Floyd murder and the awareness, the reminders about racism and exclusion and othering in our country. That may be more than you bargained on. I appreciate the chance to have spoken with you. I have a few minutes left before I have to exit, and I welcome any questions that you want to toss my way. Karen, I think, are you the moderator?
I am. I'm moderating the questions while we wait for some questions to come in from our audience. I do have one for you to start with. Certainly you painted a picture where there's, you're calling for a lot of change, and we can appreciate that. Just for a little bit of balance, what are some things that we have done well as a country that we can build from or use as a learning place and move, as a platform, move from?
Well, I'll speak to the healthcare space. We continue to do well in biomedicine and biomedical research. We've made progress, and we have provided support to the National Institutes of Health and others that are advancing the technical side of medicine. So for technocracy, not bad. We're not alone, and it's an illusion that other countries have been worse than we, and that they're not. We are part of a community, but we've done good work on doing our best. Now, that overshoots because we have devices and drugs that don't really add value, that are very expensive, but some do. For example, we today can cure hepatitis C, which was not true even a few years ago. Today, we can do organ transplants that I could not have imagined when I trained as a doctor. So we can celebrate that.
That's great.
We also have a lot of variation in our country, such that there are bright spots for lots of things. For example, if you want to see world-class end-of-life care, look at La Crosse, Wisconsin. They've absolutely changed the whole game. And they did it with medical leadership, but community leadership, and they have probably the best care for people with advanced illness and end of life, maybe in the country. We have a lot of great models of global budgeting and population-based care. The best of Kaiser Permanente, for example, is extraordinary what they do. I turn to them all the time for innovation. So we have bright spots. What we haven't really been able to do is spread that good stuff reliably to all Americans.
I hear you. We do have a question for President Darren Miller. He asks, is there a nationalized healthcare solution?
Well, that's a highly political question. I personally believe that it would be smart for our nation to move to a national health insurance system in which there would be one insurer, and we'd all have the same card, and we could, of course, vary in the benefit structures, but the enormous complexity of billing and paperwork, and it drives doctors and nurses and hospitals crazy. I think it would be far better. And we could make policy. For example, we don't have policy to end the opioid epidemic. It's killing 60 or 70,000 people a year. We had a national insurance scheme. We could say, okay, this year, this is going to be a very important agenda in our allocation of resources. I want to be very clear. When I say national health insurance, I only mean insurance. I'm not talking about nationalizing the healthcare delivery. I think that delivery system is quite capable of doing great things, but with a much more sensible payer. That's a highly political position I'm taking. That is, most people don't agree. And obviously in this presidential cycle, that was not accepted as a good idea for the country by most of the political forces. And so there's other ways to think about broadening coverage, expanding the benefits of the Affordable Care Act, and beginning to reach out to some of those populations that aren't well covered now at all. And then, of course, there is the social determinants issue. We have to find resources to put into housing and hunger and education, or we're going to continue to just keep fixing things after they're broken, and that's not solved.
Mm-hmm. Dr. Berwick, as you look around the country and you showed us the various mortality rates, whether it's London or New York, would you mention maybe one or two healthcare systems globally that you admire, and one or two traits around that?
Systems that are able to kind of focus on health in populations are the ones that catch my eye the most. Sweden is a very good example. Sweden is a single insurance system at the county level. They don't have national insurance, but they have county level insurance, region level. And in the regional level, they have a budget for the care of populations. And I've visited many times, and when they identify a problem like childhood obesity or loneliness in elders or risks in the environment, they take some of that budget and they can actually tackle it at the community level. And as a result, they have some of the highest health status in the whole world and the lowest costs in the whole world. They're a very low cost system compared to ours. And I think it looks really sensible to me. I visited a center in a community in Sweden, not so different from Milwaukee in size, in which there's a kind of a mothers and children's center, but in that same building, they have mental health services, early childhood services, birthing services, social support. So it's kind of all together, and they do that because they can think holistically. We don't have the ability to do that. Mm-hmm. The country of Scotland's been very interesting to watch. Scotland has a national insurance system. They also have a national delivery system. They have focused on early childhood experience. They have a program now called the Children and Youth Collaborative for every single Scottish village and town is part of it. And they're focusing on early childhood experiences, focusing on school readiness at age 5, I think, literacy at age 10, a couple of other variables, and they're all working together. So when my town does something, they tell another town about it, and it's pretty interesting. Yeah. Overall, I'd say smaller countries do a little better than we do.
Dr. Berwick, do you have time to take one or two more questions?
I can take one or two more, but I will have to pop off pretty soon.
Okay. So here's a question also from our audience, from Rob Blair. He asked, what impact would increased government involvement have on world-class healthcare system and delivery?
Well, it depends on the form of that involvement. I think that better government leadership in the pandemic is absolutely key. The only countries that have been successful in the pandemic have had national plans for testing, for quarantining and isolation, for public education, for masking. We don't have any national leadership, and we just hit 200,000 deaths. So that's a special circumstance right now. Overall, I mean, look, when you deal with government, of course, it's edgy. You've got political pressures, but I would say the effect of a government declaration of agendas and then resource to states and communities would be very important here. I don't know why we don't have a national campaign to end the opioid epidemic, nationally led, strategic, funded, and then deployed out, because the actual action has to occur in towns like Milwaukee. It can't be done from Washington, but I think the leadership really, really would matter. And I've already said simplification of our processes of billing and payment, they're very onerous. We spend at least 15%, maybe even more, of our healthcare budget on paper pushing. That's just not true in countries that have had a more consolidated and, in some cases, government-led payment systems. We were very complicated, and we pay a high price because of that.
Wow. I think here's one last question, maybe for now, which is from Dan Federley. Is our emphasis on diversity an impediment to equality, which seems to require a sense of social cohesion?
I don't, maybe, I wish we had time to talk more about it. I think diversity is a fabulous thing. It's whether we're willing to reach across the boundaries of our diversity to help each other. And that sense that we are kind of, in some ways, all in it together, but honoring each other's separateness and diversity, that's the line we have to walk. And I think it's quite possible in this nation. I'm afraid I have to pop off. I really
Thank you so much for your time.
I look forward to your reactions, and thank you so much. And thanks for what you do. It's great to see the Rotary Club do its work.
Thank you, Dr. Berwick, and thank you for sharing your insights.
Bye-bye now.
For all. Be sure to turn in this Thursday at noon for our snack program on Zoom to hear from Caitlin Cullen on the tutoring and meal initiatives at the Tandem. Join us next Tuesday to hear from Ken David Masur, Music Director of the Milwaukee Symphony Orchestra. As a reminder, if you would like to attend in person, we would appreciate having your RSVP into the Rotary office by 8 a.m. Friday the preceding morning. Please click the link in this morning's email or RSVP for next Tuesday. If you parked in the lot, make sure you take a parking validation. Please also remember to maintain appropriate social distancing on your way out. Don't congregate in the elevator lobby and take the stairs if you're able. This meeting is adjourned.